Hello, you are listening to the RxConnect podcast. This podcast is brought to you by the American Oncology Network. I am your host, Melody Chang, Vice President of Pharmacy Operations at Aon. Today, we are bringing our audience to Hawaii, a place most people think of beautiful beaches, amazing food, and the perfect vacation destination. And yes, all of that is true. But for the people who actually live in Hawaii, healthcare matters just as much as sunshine and surf. Caring for patients across multiple islands brings some very real challenges. Things like specialist access, travel, and logistics. That's why today's episode is special. We are celebrating the opening of Hawaii Center Care's new clinic in Maui and talking about what expanding access really means for patients. I'm excited to welcome two guests from Hawaii Cancer Care who work through these challenges every day. Joining me is Lisa Tamura, Executive Director of Hawaii Cancer Care, and Dr. Tamura, a board-certified hematologist and oncologist with extensive experience caring for patients here in Hawaii. Thank you both so much for being here.
Thanks for having us.
Um, Sure. Lisa, I'd love to start with you. For our listeners who may not know Hawaii Cancer Care, can you share a little bit about your practice?
Here, Melody. The physicians of Hawaii Cancer Care, we've been serving cancer patients in Hawaii for more than 20 years. We have a total of 8 providers, 4 MDs, and 4 APRNs, with 2 locations on Oahu, one in Honolulu and one in Aiea. And now we have our newest clinic in Kahului, Maui. We currently have 30 infusion chairs in Oahu, and we just added 3 more in our new Maui location.
That's great. So what the opening of this new Maui clinics means to the community?
Well, Melody, clinically, oncology is built on trust and consistent monitoring. So previously, many Maui patients, they relied on rotating contract physicians and oncologists there. So by providing a permanent, stable oncology team on island, we can better detect and manage their clinical symptoms.
Mm-hmm. Mm-hmm. Yeah, that makes a lot of sense, right? When care is closer to home, everything from scheduling to follow up, it just feels more manageable for patients. And thank you for doing that. So we know cancer treatment often involves a lot of coordination between surgeons, radiations, medical oncology, and primary care and other specialists. Is that coordination more challenging in Hawaii compared to the mainland? And if so, what makes it different?
I'll be honest with you, Melody, one of the actual biggest challenges we have on island is actually our lack of payer competition here. So the prior auth process for us is actually takes the longest time for us in terms of coordination for our patients. So we actually have 2, and we just hired a new care coordinator to assist with the prior auth process here. I think we spend probably about 20% more time on this than practices on the mainland, just because they require exhaustive documentation before they'll approve our treatments. For example, with prostate cancer treatment, we use genomic tests to decide if patient needs aggressive surgery or just surveillance, but these tests often require a very lengthy prior auth. And it's the same with, drugs. So a lot of times we have to reschedule patients due to these delays.
Yeah, you're absolutely right. No matter in the islands or even in the mainland, sometimes getting the prior authorizations take a longer time than actually treatment schedule itself. So very painful. And unfortunately, here you say because of the situation happened in Hawaii, less of competitions and the authorization getting more more lengthy. That's really very unpleasant situations we have to deal with. And talking about the prostate cancer, we know prostate cancer is very, very unique because it's often managed over many, many years and it rely on consistent follow-up, shared decision making, and the long-term care plan. So, Dr. Tamura, for our listeners, especially patients and families, can you walk us through prostate cancer at a high level? How is it usually discovered through the screening? And how do patients move from a primary care or urology visit into an oncology office like yours? And how do you help them understand this as something that's often managed over time?
Melody, when I talk with patients, we usually start by explaining that prostate cancer is actually a very common cancer in men, and in many cases, it grows slowly. Often you don't need an aggressive response immediately. It's something, we can manage thoughtfully over time. Most patients are diagnosed through, like you said, routine screening with the PSA blood test. And, this often happens in the primary care office. And then if the PSA is elevated or if there's other concerns, the patient may be referred to a urologist for further evaluation, which may include a digital rectal exam, prostate MRI, and possibly a prostate biopsy. And once the prostate cancer is diagnosed, not every patient sees an oncologist right away. Many are initially managed by the urologist, especially if the cancer is low risk. Cancer that is confined to the prostate can be cured with either robotic surgery to remove the prostate, radiation therapy to the prostate cancer. Sometimes, even in those cases, we add hormonal therapy. So sometimes we do get involved early. Medical oncologists will often get involved when there's local recurrence or if the cancer has metastasized outside the prostate and when treatment decisions become more complex. However, I personally believe medical oncologists should be involved much earlier, most all cancers, because I think we're the best at, guiding the patient throughout the entire cancer journey, coordinating with a lot of the specialists and even helping the patient with symptom management, even after they decide to stop all treatments. Many patients and their families are very anxious when they first see me, but I really try to assure them that prostate cancer is usually a long-term condition, such as diabetes or heart disease. Many patients live for years, even decades, prostate cancer, especially with today's treatment options. In fact, I tell patients that many people die with prostate cancer, not from prostate cancer. Because of that, our main focus has become controlling the disease as best we can, monitoring it closely, and maintaining quality of life. Of course, every patient's situation is different, so we individualize care, choosing the right treatment at the right time, and adjusting as things change. And I always remind our patients that they're not alone. Of course, they have family and friends, but here at Hawaii Cancer Care, we have MDs, APRNs, clinic nurses, we have the infusion nurses who are getting treatment, and then we have the MAs, the pharmacists, we have nutrition dietitians, financial counselors, and social workers, all working together to give the best care to the patient.
Yeah, you're absolutely right. Talking about cancer like prostate cancer, even though a lot of coordinations has to happen between the urology, primary care, and oncology, radiation therapies, And a majority of the treatment are still landed on the oncologist and happen at the oncology clinic. So develop a long-term relationship between the patients and the patient's family with the staff is really critical as well. So let's focus on the treatment first. When we talk about the prostate cancer treatment, can you give us an overview about the treatment options nowadays? So when you talking to the patients, this is going to be managed over decades, maybe. What will be the treatment landscape looks like?
For many patients with advanced prostate cancer,
Mm-hmm.
the foundation of treatment is estrogen deprivation therapy, or ADT.
Mm-hmm.
Prostate cancer relies on testosterone to grow, so lowering testosterone takes away the cancer's fuel.
Mm-hmm.
We can do surgical castration with an orchiectomy, or more commonly, because many men don't want to remove the testicles, we use testosterone blockers in the form of injections or pills.
Mm-hmm.
Now we have third generation testosterone inhibitors, or ARPIs, androgen receptor pathway inhibitors.
Mm-hmm.
These new oral drugs, such as darolutamide or Nubeqa,
Mm-hmm.
target the testosterone receptors at much higher affinity than the older drugs.
Mm-hmm.
One of the most promising new therapies in cancer, including prostate cancer, are radioligands.
Mm-hmm.
So these are targeted therapies. So there's one radioligand that targets PSMA, prostate-specific membrane antigen, that is
Mm-hmm.
highly expressed in prostate cancer, wherever it is in the body. So the first part is to use a low-dose diagnostic radioligand with the PSMA PET scan that lights up all the areas in the body where the prostate cancer is. Then we use a much stronger radioligand, lutetium-177, or Pluvicto, and it acts like a heat-seeking missile to home in all the areas that lit up on the PET scan.
Right.
The radioligand binds to the cancer cells, gets engulfed into the cell, and releases beta radiation that kills the cell. In symptomatic in bone mets, prostate cancer, there's another radioligand specifically for bone mets called Xofigo, or radium-223. It's been shown to significantly improve survival, reduce pain, and decrease fractures in the future. However, one of the biggest paradigm shifts in prostate cancer to combine some of the best therapies up front, not wait for the patient to fail one therapy before starting the next, which was kind of the previous paradigm. So we use these new ARPIs along with ADT and or chemotherapy as first-line therapy patients with lots of disease. The recent trials even suggest adding the radioligand Pluvicto up front with ADT rather than waiting until they have failed chemotherapy or the hormones.
Right. That's great news for patients, knowing they still have a lot of options, right? So you mentioned about the target therapy and immunotherapies. Many patients hear about immunotherapy and target therapies and nowadays. So do those treatments have a specific role in the prostate cancer?
Yeah, that's a great question, Melody, because patients hear those terms a lot. Many patients come and say they don't want chemotherapy, which also kills the normal healthy cells.
Right.
They're afraid of being sick, the hair loss, the nausea, vomiting. They really come with all these preconceptions. They want targeted therapies that only kills the cancer cell. And everyone likes the idea of the immune system, from our own bodies producing the kind of the ultimate targeted therapy, killing just the cancer cells. So yes, immunotherapy and targeted therapy do play a significant role in prostate cancer. But we do have to dampen some of those enthusiasms, because targeted therapies and immunotherapies are not the magic pill that cures, and they can also have significant side effects. The new ARPIs, such as darolutamide, is a targeted therapy, since it binds to the testosterone receptors on the surface of the prostate cancer cells. and inhibits the cellular signaling pathways for the cancer cells to grow. Then we also have the radioligand targeted therapies such as Pluvicto and Xofigo, as we discussed previously.
Right.
If a patient has specific mutations in homologous recombinant DNA repair genes, including like BRCA mutations, just like breast cancers, we have oral PARP inhibitors that are effective at blocking this DNA repair mechanism of the cancer cells and leading to the cell death. We also have cell-based immunotherapy vaccine called Provenge or Sipuleucel T. This helps our own immune system fight metastatic prostate cancer. Once again, it's not a cure, but has shown to allow patients to live longer, especially if done early. The encouraging part is that we learn more about prostate cancer through research and clinical trials. We're gaining more personalized ways to treat it, choosing, therapies based on the individual patient rather than a, one size fits all approach.
Yep. Yeah, very excited. And knowing the immunotherapy and target therapy are actually using for the prostate cancer, that brings a lot of comforts to the patient. Like you mentioned, the patients probably have the preconceptions. I don't want a chemo. I don't want to have a hair loss. I want to have something mild, but still strong, effective. And we talk about the coordination of care before. And when care involves referrals or inter-island travel, it can feel overwhelmed for patients or family. I want to ask Lisa, from an operational standpoint, what challenge do patients face most? And how does your team help support them?
Well, in the past, patients that were not located on Oahu have had to fly here for appointments and their treatment. And that means taking time off of work, having to go to the airport, stand in TSA lines, and then either staying overnight in a hotel or, going through that whole process to return home. Though our team, including financial counselors and a social worker, we help to make those arrangements or try to find financial patient assistance in those instances. But now with the addition of our new Maui location, we're providing Maui residents with greater access to the high quality patient-centered cancer care that we provide closer to home so that they don't have to go through all of this rigmarole to travel to Oahu to get treatment. And we're hoping to expand to other islands also, so that they have access to the high quality care that we can provide them also.
Okay, that's great. We know within our American Oncology Network, we have some clinics located in a place that people like to travel and the people like to have a vacations like Florida and like Hawaii. So for the patients, they continue to getting the treatment, but they don't want to just put a stop in their life. So they will still want to have somewhere to go. So that's a very comfort for us to understand. We do have access no matter where you go. That's wonderful. So I think we're going to wrap up for today's episode. And before we wrap up, I'd love to hear one final thoughts from each of you. I'll start from Dr. Tamura. What's one message you want a patient and family to take away?
So, any cancer diagnosis, including prostate cancer, cause a lot of anxiety in patients. Apparently, it's a death sentence, right? They're going to die immediately or endure a lot of pain and suffering. The treatments for prostate cancer are advancing all the time. The most promising being these targeted therapies, including the radioligands. But we're discovering new genetic mutations that are driving the growth of prostate cancer, and maybe the help of AI in research, we can find more effective targeted therapies much faster than years in the past. So there's a lot of hope.
Yeah, talking about AI, we probably have to reserve another episode just talking about AI alone on the cancer treatment. And how about you, Lisa? Any final thought?
Yeah, I just like to say with our Hawaii Cancer Care team, we have people to assist through this whole process. Our APRNs and nurses, we do patient education. And like I said, our financial counselors will assist with financial needs. And we have social workers. So we're here to support prostate cancer patients and their families through the whole process.
Thank you so much. Thank you both so much for joining us today and for sharing your perspectives on expanding access to cancer care in Hawaii. And thank you to our listeners for tuning in. We hope you enjoyed today's conversation. And this episode is brought to you by American Oncology Network. And today's episode is supported by educational grant provided by Bayer. I'm your host, Melody Chen. Thank you for listening, and we will see you next time.
The RxConnect podcast is produced by the pharmacy operations team here at American Oncology Network and music composed by the Synth Dude. Make sure to check out all our episodes of the podcast by liking and subscribing to our YouTube channel.